Good morning, good morning, good morning, and welcome to the Great Lakes Health Radio program with Kaleida Health and your host, Francesca Messiah, Manager of Workforce Development. Well, we are in the month of March, and if you didn't know, March is colon screening month. That's your colon. Therefore, the first half hour, we will discuss colon screening, the importance of screening, who should get screened, and the different types of screening. In our second half hour, we'll have an expert talking about child psychiatry. And questions such as, you may have questions such as, who to contact if you feel your child, your grandchild, your foster child, your friend's child could benefit from meeting with a psychiatrist. Well, let me just give you a little bit of overview. Who is Kaleida Health? Kaleida Health are the hospitals and clinics located in Western New York, and Pennsylvania, and Olean. And our hospitals in the greater Western New York area include Buffalo General Medical Center, Oishei Children's Hospital, Millard Fillmore Suburban, Gates Vascular Institute, the Visiting Nursing Association, and throughout the area, north of the city, south of the city, in the city, we have clinics and specialty clinics for children, men, and women. So, in other words, we service the entire family, the entire community. Moving on. Okay, so our first guest for today is Dr. Paul Shields. Good morning, Dr. Shields. How are you today?
Good morning, Frank.
Okay. You're breaking up just a little bit, but that's okay. We can still hear you. Let me just say that Dr. Shields is is a physician, and he is the CEO, Chief Executive Officer, and the Chief Medical Officer of GLIN IPA. GLIN is a part of Kaleida Health, and they're the Great Lakes Integrated Network. They are physicians who are part of our wonderful system. So let's begin the program. Doc, Dr. Shields, I had a colonoscopy a few years ago. People complained about it, but I can tell you, I felt, not only did I feel great afterwards, my results were great. So I would like you to share with our listeners, why is colorectal cancer screening so important?
Yeah, thanks. It's funny. The only people who complain about the prep are people who haven't had the prep.
Oh, okay.
It's a lot of rumor and misfact. Once you've been through it, it's really not that bad. And you can, there's some tricks to it that we can talk about. But colon cancer screening is so important because you only find the cancers you look for, and you can only treat the cancers you find. So it's a very easy test. Once you find colon cancer, the easier it is to treat and the better patients do. So getting screened is critically important. It benefits through almost all insurances. There's really no reason not to do it except the people who like to tell you it might be bad.
At what age should people begin getting screened? And does family history have anything to do with when one should get screened?
Yeah, good question. The current recommendation is everyone 45 and older should be screened for colon cancer. It used to be 50. A lot of people will remember the age of 50, but recently we've reduced that. The national recommendation is 45 years. If you have a family history, if you have a family member who has had colon cancer, your primary care doctor will recommend that you get screened before 45. And that's really a very individualized recommendation. So make sure that if you have a family history, you connect with your primary care doctor to see when you should start getting screened for colon cancer.
Mm-hmm. Now, I know that, sorry. What, and I know because from doing a lot of health screenings and such in the community, I know there are some organizations, I'll say Erie County, I know they have it's a kit that you take home and you mail your stool in. So can you just discuss what are the different types of screening that are available, and how does the kit that you mail your stool in compare to colonoscopy when it comes to an accurate screening?
Sure. There's really three available tests. One is called Cologuard, one is called FIT, F-I-T, and then you have the colonoscopy that's available. They all are a good screening test for colon cancer. If you are asymptomatic and at average risk, so most of the population, any one of them is fine. The limits and the differences are FIT testing, which is you test the stool that you put on a card and mail back into a lab. That has to be done every year. Cologuard can be done every 3 years. Same test, you move your bowels, piece of the stool goes on to the card, you mail it back in. And then a colonoscopy can be done every 10 years. So the benefits are it's much less invasive, obviously, to mail a card in, but it has to be done more frequently. The colonoscopy can be done less frequently, but it's a procedure. You have to prepare for that and go in. The reason that I like somebody to go for screening to a colonoscopy is the colonoscopy can be the definitive test. So if they find a polyp or if they see something abnormal, at that point, they can address it. The FIT test or the Cologuard, if it comes back abnormal, and what it does is it tests for blood and abnormal DNA that would be suggestive of cancer, the recommendation for an abnormal stool test would be to have a colonoscopy. So there is value in just doing the colonoscopy. But if you're absolutely opposed to having a colonoscopy done, the FIT tests are a good test for people of average risk to have done at those frequencies. FIT every year, Cologuard every 3 years.
Thank you. And and that makes sense why sometimes people will, like, again, doing wellness fairs and asking people about colonoscopy, they're like, I have to get it every 3 years. But I didn't know that maybe they're talking about a Cologuard and not a colonoscopy. So thank you for answering that question.
If you have an abnormal colonoscopy, you would have to then be more frequent. So if they go in your colonoscopy and they find something abnormal, they take a polyp out, or God forbid, they find a cancerous lesion, then it wouldn't be every 10 years. You would be on a more accelerated schedule. You would likely need a colonoscopy more frequently if your first is abnormal.
Mm-hmm. Now, as I mentioned earlier, I had a wonderful experience with a colonoscopy, but what should people expect during a colonoscopy?
Yeah. During the colonoscopy, you've got probably 30 minutes. It's about 15 minutes. So the procedure itself is you'll go into a sterile procedure room. They'll give you some medicine to make you relax and what we call conscious sedation. So you're theoretically not under general anesthesia for most of these procedures. You'll lay on your side, and then the colonoscope, the actual camera that they use, will be inserted into your colon. It will go all the way up your colon to where your appendix is, and then they'll bring the scope back out. So it takes about 15 minutes to get the whole way in, and then it takes about 15 minutes to get back out. So about 30 minutes of a procedure, and that gives the procedure the ability to look both times. So the doctor who's doing your scope actually gets to look at your colon twice, going in and then coming back out. So it's a very good look at the colon for any abnormalities. Then you'll wake up, be taken to post-recovery. It takes about an hour or two to really kind of not have the nausea or cramping that some people have. And then it takes about 24 hours afterwards for all of the medicine that you were given to kind of be sleepy to wear off. So we recommend that you don't drive or operate equipment in the day after the colonoscope. And the real benefit here is that people don't usually remember it. So the medicine that you get, you don't have memory of the procedure itself. It's really quite a pleasant procedure to go to. Some people tell me they have the best rest of their life in that day after the colonoscopy.
That's true. And I know nowadays, I know I had, oh, I'm not sure if it's the same for colonoscopy, but I don't know if you can even have it unless you have someone to bring you home. And I know one of the tests I recently had, it said no taxi, no Lyft, no Uber. You have to have someone who can actually give you a ride home because you can't drive afterwards.
Yeah, we would not let you drive, and it's always best, just because you could be a little bit groggy. It's best to have somebody get you home and into your house. And, yeah.
Yes, I agree. Are there less invasive screening options for those who are hesitant about everything that you just described during a colonoscopy?
So there is an option of the fit test or Cologuard, which is absolutely fine to do. So for somebody who's hesitant or resistant to do that, um, in some areas there is an emerging what they call virtual colonoscopy, which is a CT scan. I don't think that is something that most patients should consider, only because the preparation is the same. You still have to clear your bowels out, so you still have that day to 2 days before where you're preparing your bowels, and it is a virtual test. So anything, again, like the fit test or Cologuard, any abnormality that would be seen would then prompt you to need a colonoscopy. And I think colonoscopy and the stool tests are really the best options for patients today. So if you don't want the invasive procedure, the stool tests are so easy to do and readily available that there's really no argument against that.
Yeah, thank you. Now, what are some common myths or fears about screening, and how do you address them?
Yeah, the biggest one is the prep. There's a lot of misnomer that, oh, it's going to be terrible and I can't leave my house, or I can't do any of these things. Um, so the real piece of the prep, so the preparation is to clear your bowels out. And that has to be done so that the colonoscopy can be effective, that they can see the wall of your colon. And the best thing to do for that is to prepare about 3 days before your colonoscopy. So what I tell patients is go on a very bland, no processed foods, no ultra processed foods, really as bland of a diet, kind of like if you were just recovering from a gastrointestinal, bananas, rice, applesauce, toast. And then on that second day before, or even the day before, go on a clear liquid diet. Really work to get your colon cleaned, because then the prep, the medicine that you're going to get to clear that out doesn't have to work aggressively hard, because most of what's coming through is liquid already. And that if you can prepare for the colonoscopy 3 days before with really getting your diet under control and limiting it, the prep itself is really nothing to even be concerned about. The other piece is people think that the colonoscopy is painful. It is not painful. There's really no pain, no perception. It's not. So really just allaying the fears that this is going to be a painful procedure. And then the biggest is there's this level of embarrassment. People say, well, I'm going to have to lay on a table and they're going to put a tube in my rectum and I'm embarrassed by that. And a lot of that is just working through the piece of, I would rather spend 30 minutes of theoretical embarrassment to find a cancer that would save my life, rather than ignore that and have a terrible outcome. So some of it is just the reassurance that there's nothing to be embarrassed about here. These doctors and nurses and providers are looking at a screen that the camera is putting an image onto. You're fully draped for the procedure. It's like any other medical procedure. There really should be no embarrassment around this. But those are the three big things that I hear from patients.
And what's amazing is that no one sees you except for the physician and the medical team.
Yeah.
So no one else, your friends, your pastor, no one sees you. So you shouldn't be embarrassed because you don't want the outcome. Because you don't want colon cancer. So
Yeah.
again, this is all about prevention. Now, you talked a little bit about diet, but let's say diet overall. How can diet, exercise, and other lifestyle changes reduce the risk of colon cancer? I mean, so I'm just saying if you enjoy pizza and wings and ribs and mac and cheese and iced tea and maybe vegetables with cheese, and some fresh fruit and some water. What are some, how can diet, exercise, and, help out the risk to reduce colon cancer?
Sure. And there are some specific things and some general things that impact your risk for colon cancer. Obesity in and of itself is a risk factor for everything, quite honestly, but it does increase the risk for colon cancer. So maintaining a healthy weight by eating a moderate diet and maintaining an exercise profile is good wellness, and it will help reduce the risk of colon cancer. Heavy alcohol consumption is an independent risk factor for colon cancer. So moderation, I'm not by any means telling people that they cannot consume alcohol, but excessive alcohol consumption is a risk factor for colon cancer, and that should be consumed in moderation for a whole host of reasons, but also to reduce that risk. And the consumption of red meat and processed meats, so sandwich meats, cured meats, red meats that are a dominant part of your diet, do increase the risk. So again, that should be in moderation. We shouldn't be eating those kinds of foods every day for every meal. You can eat them by all means. You should have a balanced diet, but you have to make sure that if you're eating processed cured meats and red meat 7 days a week, 3 meals a day, you have an increased risk of colon cancer. Moderate activity goes a long way to maintaining a healthy lifestyle and weight, but activity that people are able to perform on a regular recurring basis reduces inflammation in general in the body. And inflammation is a risk factor for multiple types of cancer, colon cancer being one of them. And the way we reduce inflammation is by keeping blood flowing to those tissues. And the way you do that is by staying active and keeping your heart working and pumping. So moderate activity is a good way to reduce inflammation and will help reduce the risk factors for colon cancer.
No, that was very that was good. That was interesting. Is colon cancer becoming more common? You talk about processed foods. There's so many processed foods in the market. There's so much sugar in the market. To me, it's like overload with, different coffee shops making drinks and such. Is colon cancer becoming more common in younger adults? And should they be concerned?
It's interesting because of all of the work that we do around cancer. And when you look at colon cancer in the older population, and the more gray I become, the further I push that number up. But if we look at it from 40 and up, colon cancer incidence is actually flat or decreasing in most of those age groups. From 18 to 39, so 18 years old to 39 years old, it has almost doubled in the last 2 decades, the incidence. So it is on the rise. I don't know exactly why. I don't know that anybody has said exactly why that is, but younger people are at risk. Now, with that said, the screening is still not recommended until 45. But for that age group, that population, it is possible, and they should be aware. And if they have symptoms that are concerning from a GI standpoint, a change in your stool. So you normally have one type of stool and it's changed. If you have bleeding from the rectum, if you're diagnosed with anemia or have cramping or symptoms in your stomach, you should see your doctor. And it is reasonable then to even do a colonoscopy, not from a screening standpoint but because of symptoms, because colon cancer can happen and does happen in people less than 45. And it is happening at a higher rate. Over the last 2 decades, it's almost double. It's 80% increase in the incidence of colon cancer in that younger age group up to 39.
And what if someone does, number one, you should look at your stool. Just don't flush it all the time. Look at your stool. What if someone does see, let's say someone is 40, they see blood in their stool. Should they just say, well, they said nothing can happen to 45, or should they call their primary care at that point or call your office? What should they do?
Absolutely. This goes to a point that isn't necessarily related to colon cancer, but everyone should have a primary care provider that they trust. They should have a relationship And if you notice blood in your stool, if you notice a change in your stool pattern, you should make your primary provider aware of that. Doesn't mean that they're going to make you come in for an appointment, is that they can give a lot of recommendations over the phone or through the portal and however you communicate with your provider. But those changes need to be alerted. It is not something you should ignore. Now, with that said, most times bright red blood in a young person is not something that is of significant concern. There's a lot of other things that can cause it, but you should not ignore it, and you should have somebody assess all of your symptoms and make sure what the next step is and how you look at that. It should not be ignored.
Mm-hmm. Where should people go for screening if they don't have health insurance or a primary care doctor, and what should they do?
Yeah, if you don't have insurance, the Erie County Department of Health, if you go on their website, Cancer Services, they have a program to help pay for screening colonoscopies. So in those patients 45 and older, if you don't have a doctor, you can obviously go through all the channels. Kaleida Health has Find a Physician on their website. We also have 716-800-CARE, CARE. You
Say
can
it one more
call
time. Say that one more time, that phone number.
716-800-CARE, CARE. And that you can be connected with a care navigator who will help you get a primary care physician and can also help you get scheduled for a colonoscopy if you're in that age group and need to have a screening colonoscopy done. So it's what we call a lay care navigator. It's a community person who helps patients connect and navigate through the healthcare journey.
And I can't say enough about the care navigators. They're wonderful. And what's one key takeaway message you want listeners to know about why they or their loved one or their good buddy, their good girlfriend, their boyfriend, what's one good takeaway why people should have a colorectal cancer screening?
I think the biggest takeaway from this, and this is more of a personal for me, I rarely see bad outcomes in patients who get screened and get diagnosed early. Where I have challenges is patients who ignore symptoms or who ignore screening and then have a very late stage cancer that there's very little for us to do. And the frustration in that is this is an easy, readily available, covered test that all you have to do is show up and we can get to the answers and get to treatment so efficiently and avoid so much angst in a patient's life. This is one of those things. Colon cancer is very easy to treat in most cases, especially when we find it early. And we have a great test to find it, but we don't use it enough. In New York State, just about half of eligible people get screened every year. So we have a huge opportunity to do better. And we need to take the stigma away from it. There's nothing to be embarrassed about. It's not painful. The prep is nothing to be concerned about. You should go have this test done because it could save your life.
Okay. Dr. Shields, I want to thank you for being the guest on the Great Lakes Health radio program. And our topic has been colon cancer, screening for colon cancer. And listeners, stay tuned. We have our second half of the program coming up within 30 seconds. And now on to part 2. And welcome to the second half of the Great Lakes Health radio program with your host, Francesca Messiah from Kaleida Health, Manager of Workforce Development. Well, in our first half hour, we talked about colon screening, colon cancer, which targeted more the adults. And Kaleida Health, as I always mention, we have a full children's division. So I like to have balance between guests who work with the children. So this morning, we have a treat, and we have the treat of having Dr. Dory R. Marshall. Good morning, Dr. Marshall. How are you?
I'm well, Francesca. Thank you so much for having me.
Oh, you're welcome. And Dr. Marshall is the Chief Medical Officer at Oshai Children's Hospital, and she is a pediatric psychiatrist. welcome to the show, Dr. Marshall.
Thank you so much. I'm just going to correct you. So I call myself an adolescent psychiatrist because that is that is the work that I have done predominantly throughout my career. But I did not do a fellowship that would allow me to say that I'm a child and adolescent psychiatrist. So that is the caveat. I've worked with kids for most of my career on the adolescent unit at Erie County Medical Center. And that really is where my passion lies.
Thank you. And yeah, and I have something I have to share with you. When I was probably up until about fifth grade, when people asked me what did I want to do, I wanted to be a psychiatrist. And I was discouraged at a young age. So I just want to say this was an area that has always interested me because up until a good fifth grade or so, this is what I wanted to do. It was be a psychiatrist.
Goodness, I'm so sorry that anyone would discourage you from that. I think for on so many levels, it's important for us to encourage young people to follow their passions and do what they're excited about doing. And I think that it probably, I don't know who it was that was discouraging you, but I suspect that there was a stigma associated with mental health, mental illness, and working in that sphere. And maybe that had something to do with it.
Yeah, or it also could have been a fear. But you know what? Along those lines, what led you to the path of being an adolescent psychiatrist?
Well, I am a Buffalo girl. I grew up in Western New York, went through the public schools in Amherst, and then went to UB as an undergrad where I majored in psychology. I thought it was fascinating, trying to learn what motivated people and, you know, what, you know, what helped people when they found themselves in situations where they were struggling with a mental illness. It wasn't part of the plan in their life's course, but hit them at a certain point in time. And so that was an interest of mine from undergraduate years. Ultimately, I went to medical school and, found that I'm a people person. I want to work with people. I want to get to know them. I'm driven by curiosity. And when somebody tells them a little bit about themselves, I want to know more because I really do believe that when you understand enough about a person, everything that they do and everything that they want makes sense. But it takes a lot of talking and a lot of, asking questions in order to get to that point where you can really understand where somebody is coming from. And so I think that really led to my interest in psychiatry. And when I was a resident in psychiatry here at the University of Buffalo, I spent about 3 months in my last year of residency on the adolescent unit at ECMC. I loved working with the kids who came to that unit. I loved working with their families. And I found that was the most meaningful work that I had done to that point, which is why I stayed there for the next, 11 years.
11.
Yeah.
Mhm.
Mm-hmm.
Okay. So, and when we say adolescent, what age is adolescent? Because my next question, I had children, but it should be adolescent. And I just want to make sure that our listeners know what age are we talking about when we talk about adolescence?
We can talk about children. We don't have to limit it to adolescents. I mean, that's the age group that I worked with primarily. But we can talk about, child psychiatry more generally, for sure.
Okay. So then why would a child need to meet with a psychiatrist? And what is the youngest age? So if we have that a child would come and or a parent, a grandparent, a foster parent would see you.
Yeah. So I think that it really depends on the child. And I would say that the rule of thumb is that when there's a change in behavior, um, from baseline to something that's concerning, that's when, parents, caregivers, grandparents, teachers, that's when their antenna go up. And They are, at that point wanting to know what's wrong. And if it's the change in behavior that's based on a physical ailment, say that, child is, all of a sudden limping, right? That is going to drive the child to the pediatrician. If a child's behavior, their sleeping is suddenly, very different, or their eating is suddenly, very different, they might start with their pediatrician, but depending on, what accompanies those changes, the pediatrician or the parent or caregiver or teacher might think that it, needs to be evaluated by, a child psychologist or a child psychiatrist. And it's really those changes, a child who suddenly becomes very withdrawn at any age, right? It could be, 2, 3, 12, 13, 18. When a child, suddenly has a change in their behavior that's of concern, that's when you start thinking about bringing in a mental health professional.
Mm-hmm. And are the children seen? Are they inpatient if something happens to them and they're in the hospital, or are children seen as outpatient, meaning that they would come into a clinic or an office?
Yeah, and I think that's a great question, Francesca, because I think some people have preconceived notions about what psychiatry, entails, and it can be both. Sometimes a child is, having a physical illness. Maybe they're dealing with a chronic condition like sickle cell disorder, and they're in and out of the hospital, having pain crises, or, something along those lines, or they might be dealing with a cancer diagnosis and be in the hospital for a long period of time. And in those instances, a child might be seen because they're struggling with, depression, they're struggling with, sadness that lasts for weeks on end, and they need to be evaluated by a psychiatrist or a psychologist on an inpatient setting. Another time when we might see children who are seen on an inpatient setting would be if they're struggling with acute suicidality,
Mm.
and they come to the hospital and it's just not safe to discharge them. And in those instances, we generally at Children's Hospital would see them and assess them, but then would transfer them either to GLIN Hospital or to Erie County Medical Center's Adolescent unit for longer term inpatient care in a psychiatric setting.
Mm-hmm.
So, if a child needs to be in the hospital for a medical reason and they are struggling with a mental health disorder at the same time, again, depression, anxiety, or a thought disorder, or another mood disorder, then certainly they can be treated on an inpatient setting here at Oishei Children's. If a child is struggling with a mental health disorder primarily that needs to be, dealt with more acutely on an inpatient setting, we would transfer to GLIN or to ECMC and they would get care there. But then, that would be followed by outpatient treatment. And there are lots and lots of, kids who never end up on an inpatient unit and seek outpatient care, at our mental health facility, at the Child and Family Clinic, at Kaleida Health, or at one of the other partners in our community that provides outpatient care for children.
Mm-hmm. And I just want to let our listeners know, in case you're not familiar with GLIN, GLIN is located in Buffalo.
Yes, yes.
And so it's as well as Erie County Medical Center. But I just want to make sure in case someone didn't know. And I'm assuming you can visit your child at any of at ECMC if they're in the patient there, or any of the sites you mentioned.
Absolutely. I think each hospital system has its own visitation, policies about when visitation is and how visitation is managed. But you can't have a child in the hospital and not have family involved. So, So absolutely. I know that both at Bryland and at Erie County Medical Center, families are welcomed and, and needed to visit and attend meetings and be supportive of their child.
Thank you. Now, why is this a topic of growing interest? My thoughts, but that's why I have you on the show, because you're the expert. I feel that social media has a lot to do with could have a lot to do. It may or may, but you are the expert, and that's why I have you on the show. So, why is this topic of child psychiatry, adolescent psychiatry, is I should say, is it a growing topic?
Oh, it's definitely a growing topic. And I think there's a lot of reasons. I think COVID uh, was, a period of time that was extremely stressful for children and families, especially for children whose parents were essential workers. And so, I think during the pandemic, I know at the adolescent unit at ECMC, there was no slowdown in admissions. And some of the children who came in during that period of time were sicker than I've ever seen. It was just a very stressful time for many children. It was scary. They lost the support of their schools for that period of time because they weren't in school. And so all the safety networks that are in place in a school were lost to the kids during that period of time. And parents were under, extreme stress, which, certainly impacts kids. But even before the pandemic, I think your question about social media is astute. Um, Social media can be wonderful. It can help in lots of ways. It brings connection to people who've been out of touch for years. It brings resources to the foreground where people may not have known they existed, and so it can be a very powerful, positive communication tool. But there are downsides, and I think technology hits us quickly, right? It's not like having a cell phone was something that snuck in over 4 decades and gave us time to get used to it. It was sort of like overnight, all of a sudden, everyone had a cell phone.
Right.
Right. And, I told parents for years that, if they thought back to their childhoods, and we had telephones in the house, we had some rules constructed around telephone use. For my family, the rule was you didn't call anyone before 9 a.m, even on the weekends.
Right.
And you didn't call anyone after 9 o'clock at night. And, so there was downtime. You got off the school bus, you went into your house, and you were free of any bullying or any drama that was happening at school. And you had some time to focus on your family.
Right. Yes. Yes.
And I think that, what I've seen with cell phones is that in instances where parents aren't providing some structure around, or some rules around when the cell phones are used, you have children getting off the school bus and coming home, and they never get a chance to turn off what's happening at school. And so they can be bullied at 4 p.m. They can be bullied at 10 o'clock at night. They can be bullied at 2 a.m. And mom or dad or grandparent, they have no idea that the child is being bullied in their bedroom. They think that their child is safe because they're at home, and they actually, are getting hit with things while they're in the safety of their home.
Yeah.
So that's, I think, something that we all need to give some reflection on, and think about, how do we give our children the opportunity to be connected, but not harmed when they're, on their phones and using social media.
Mm-hmm. Yeah. And even you think about church, you could be bullied right there on Sunday morning.
Absolutely.
Or if the Jewish faith on Saturday morning, because everyone has cell phones, and you, like you said, you can be bullied 24 hours and unless you have those controls on your phone. Next question: what types of services are available? So, is there such a thing as a first visit, or what would a first visit look like if a if that caring adult is bringing their child to see you or one of your colleagues who's a psychiatrist? What would that first visit is there a typical way of a first visit?
Yeah, I think that that's a great question, and maybe to demystify it, I would say a first visit should really be about getting to know the child and getting to know the family a little bit, because to what I said earlier, you can't start drawing conclusions until you've asked all the questions, and so you have to get to know, who is this young person that's coming into my office. You know, who's this child's family? Who's this child's, school network? Who are their friends? And, what interests this child? What motivates this child? Um, is this, what does this child have to say about why they're coming in for this visit? Are they struggling with things going on at school? Are they struggling with things going on in the home? Are they struggling academically, and that's, making it just frustrating all day long, because all day long they're feeling frustrated in their school environment. And so an intake really is about asking a lot of sort of baseline questions to get a sense of, and not an in-depth sense, but, just sort of a first glance at who is this child and who is the family that provides the context for the child, if that makes sense.
Mm-hmm. No, that makes total sense. I know you said struggle. When you talked about the struggles, you mentioned struggles in the home or struggles in school, and I'm just going to add one more struggle between school and home, because sometimes that child could be bullied somewhere between, let's say, the safe place of school and the safe place of home, and there could be that in between, which brings me to my next question. What is your advice for our listeners, for our caring adults, parents, grandparents, foster parents, who may see this and that young person in their household, and they're struggling at what they should do? What what should they do if they see that? Any of
Well,
the yeah,
yeah, I mean, they should absolutely reach out. I think for some people, the first call is to the pediatrician, because they have a relationship with their child's doctor, and their child's doctor can be, a starting point for addressing the concerns that the parent is seeing, or the caregiver is seeing, or, like you said, all the people.
all the people.
people. Um, they can also, if it's a more acute concern, if it's like, oh my gosh, this is terrible, what do I do right now? They should call crisis services, because
Yeah.
crisis services can talk to them on the phone right now. And if needed, they can send somebody out to assess the child and assess whether there's a need for ramping things up a little bit. And, we have, if it's a concern that is not an immediate concern, but something where the parent wants an assessment, wants an evaluation, the Children's Psychiatry Clinic at Oshai Hospital. I can give you the number, I think, at the end, for people, if they want to write down the phone number to call to get an appointment and to get that child in for an assessment. It's really not a threatening environment. It's full of therapists and psychiatrists who love kids and love their families and want to take care of them and want to offer assistance whenever they can. So I can give you that number if you want me.
Yes, yeah. Because why don't you give that number, and then I have the number of crisis services, which has a 24-hour hotline. So why don't you first provide the Kaleida number, and then I'll provide the 24-hour hotline number.
Okay. So the Kaleida Health Child Psychiatry Clinic is 716-859-5655. 5460. So 716-859-5460.
Okay, thank you. And then the 24-hour line for crisis services, also in Buffalo, it's their 24-hour hotline, is 716-834-3131. Again, that's 716-834-3131. Yeah.
Yeah, and I think there may also be a crisis services kids helpline, Francesca, which is 716-834-1144.
And say that one more time, please.
716-834-1144.
Yeah, thank you. Who is responsible for making the appointment? I think at one point in time, maybe teachers could, but is it the teacher, the parent, how is that determined for who is responsible for making that call of concern?
Well, I think certainly if teachers have a concern, they have every, right responsibility even to reach out and let someone know. And that could be the parent, or the parent figure, or the counselor at school, or even a school nurse. I think, many of our elementary schools have school-based health clinics. And so reaching out to the clinic might be a first step. But at our child psychiatry clinic, we would want a parent to call to make the appointment, because they would have to give consent for care. Now, crisis services, anybody can call. So I think your question about teachers calling crisis services, if a teacher had a child that they were, imminently worried about, they certainly could call crisis services themselves. And I suspect that each school probably has its own protocol for how that's handled.
Mm-hmm. Yes. Well, Dr. Marshall, we've been talking quite a bit about adolescent child psychiatry, but let's switch roles. Your hat as Chief Medical Officer at Oshai Children's Hospital. It's Women's History Month. That is a huge role. What exactly is a chief medical officer, and what are your responsibilities?
So it's a good question. Thank you, Francesca. So my role as chief medical officer is really to answer to all the physicians who work at Oshai, whether it's in the hospital or in the outpatient settings, and to try to facilitate their giving the best care to the women and children that we serve that they can. So I work very closely with the physicians and with the physician leaders to try to streamline the services that we offer, and make sure that we are addressing all of the needs of the patients that we serve here. I think, it may be Women's History Month, but it's always women's healthcare here at Children's Hospital, and children's healthcare here at Children's Hospital. So, yeah, I appreciate that question.
Yeah, well, you know what, and that's how I feel about a lot of times when they'll say it's breast cancer month or colon cancer month. I understand the importance. However, you should get screened, or every month those health um those health challenges can come into any of our lives. So I like how you phrase that, how Women's History Month, that's still the concern.
It's 12 months out of the year here.
12 months out of the year, exactly. We have a few minutes remaining. Is there something that you would like to focus on? Something you want to add? A question you want to add more content to?
I think I just would like to reemphasize that, when a parent or a caregiver is concerned about a young person, it doesn't matter if the child is 4 or 17. It's really important to pay attention and to get help when they have that concern. So, I think sometimes children's mental health gets hidden, and you can have a child who's very, very depressed, and it takes a while to read it through changes in behavior. So once you start to see those changes and feel like something isn't right, it really is very important to reach out. And again, you can start with the pediatrician, or you can pick up the phone and call, our children's psychiatry clinic. But it can absolutely be life-saving to make that call and to start focusing on what's underlying, the child's distress. So, yep, I appreciate you giving me sort of the forum to talk about this, Francesca.
Oh, you're welcome. And I know parents sometimes, grandparents, sometimes you may have been raised if something was strange to spank, but sometimes that's not it. Sometimes they may need to give us that number again, Dr. Marshall, if you could.
For the child psychiatry clinic?
Yes, please.
It is 716-859-5460.
Well, thank you so much. Dr. Marshall, we are out of time. And I just want to thank you so much for this very important topic. Thank you for taking time from your busy schedule to share your knowledge with the community here on the Great Lakes Health Radio program.
Absolutely. Thank you.
And listeners, next week, you will hear from my esteemed colleague from Erie County Medical Center, ECMC, and that's Cindy Bass. And God be willing, in 2 weeks, you will hear me in 2 weeks with another interesting topics from Kaleida Health. We have over 13,000 employees, and I promise every other week we're going to have topics that are of interest to you and to our community. Thank you. Bye-bye.